Welcome back to my channel in the new video, and this is a series on nutrition in ICU. I will again divide it into two parts, two videos, and this particular deliberation I did during the critical care conclave in the month of November at Amritsar, organized by ICCM Punjab chapter. So without further ado, let us start. Now, I will be referring to the standard ASPEN, that is American Guidelines 2024, and ISPEN, that is European Guidelines 2023 for the same. So, talking about nutrition in general, there has to be a review of the malnutrition in the form of risk assessments or screening. We need to outline the timing, the routes of administration, either EN or PN, and as we know, the emphasis has always been on enteral nutrition, and of course the dosing as per the guidelines. I will take into account the perioperative aspect and the ERAS concept, that is early recovery after surgery, and that forms an important and integral part of nutrition in any multidisciplinary ICU, with the special mention on the special population, and of course the evidence gaps and the practical implementation of the same. So the importance of nutrition in critical care needs no uh, further explanation, that everyone is clear about it. So what are the metabolic changes in the critical illness which affects the loss of the lean body mass, which is 10% significant, and 20% it causes the critical illness, and it is more than 30% is lethal for the body. And multiple factors are important for the metabolic changes, including the acute phase responses, the insulin resistance, the low T3 or the sick euthyroid syndrome, and the catabolism which sets in. Usually we need to think about and deliberately make an attempt so as to start the enteral nutrition as early as within 48 hours of admission, and we need to target about 70 to 80% of the energy requirements and the protein requirements thereupon. So it actually starts within, say, initial 48 to 72 hours, and then the target goes up to about 7 days initially, and so it is not achieved on the second or the third day itself. Gradually it is increased, and then we achieve that target. So for that we need to have some screening tools. As we know, the standard NRS 2002, the Nutric score, and of course the clinical frailty score. So of course we have the strengths and the limitations of each one of these, and you can read it for yourself. Having said that, I would like to emphasize here that indirect calorimetry forms the mainstay of the energy expenditure screening as a standard tool for any patient admitted to a ICU in a critical state. So if I have to speak about the futuristics, we need to have to bearing in the mind that the indirect calorimetry is a part and parcel of any clinical dietitian or a dietetics department of any tertiary care hospital. And just to add upon it, initially we used to have quite a bulky instruments for the indirect calorimetry, but now we have the machines which are quite, less bulky in nature, more user friendly, and can be used in any ICU setup with a great efficacy. As far as malnutrition is concerned, as we know, ISPEN guidelines states that more than 10% of body weight in the last 6 months is significant. Any BMI which is less than 18.5, and we encounter malnutrition in about 50 to 66%, which is a very high number. They have increased susceptibility to infection with poor wound healing, and of course increased chances of decubitus ulcers, overgrowth of bacteria in GI, abnormal nutrient losses through stools and delay in the surgery. So when we talk about preoperative nutrition, when you see that where we have a oral form or EN or PN in few subset of patient, when the EN is contraindicated, we can see that the complication rate drops by about 10%, which is significant. And we obviously think of any lipid free solutions into this. As far as post-operative nutrition is concerned, as I said, initiation of EN within first 24 to 48 hours have a direct bearing on decreasing infection with in some patients where you have pancreaticoduodenectomy, where you prefer parenteral nutrition, where you have pancreatic fistulas, and we need to actually emphasize it with a multidisciplinary approach with involvement of clinical dietitian, the intensivist, the primary physician or a surgeon, and of course the nurses, and empowerment to nurses and the clinical dietitian is the need of our in 2025. How we go about initiation? Of course, oral is preferred. If not, then enteral nutrition. If not, then the parenteral nutrition. In the patients who have risk of aspiration or has evidence of gastric intolerance, we go ahead with the post-pyloric feeding modalities. And Aspen especially talks about the PN and the EN equivalent for similar calories in the early phase. No PN in the first 7 days whatsoever. And ISPEN actually talks about early progressive PN in malnourished patient if the EN is contraindicated. And here it is called as partial parenteral nutrition or PPN. As we know, the energy requirement of anywhere from 12 to 25 kilocalories per kg per day in the initial 7 to 10 days. And of course, we need to avoid more than 100% measured energy expenditure to prevent overfeeding. So sometimes what happens is, in process of early feeding, we tend to give them overfeeding. So there is a huge difference between the early enteral nutrition and achieving the targets in the next 1 week or so, and overfeeding approaches. Proteins, of course, we target up to 1.2 to 2 grams per kg per day. And here we usually talk about the absolute contraindications to enteral nutrition, and this has to be very, very clear in our minds. GI obstruction, ileus, acute severe GI bleed, perforation, severe shock or uncontrolled shock, abdominal compartment syndrome, and high output proximal fistulas. Now, this has to be very, very clearly registered in our minds that these are the absolute contraindications of enteral nutrition. And apart from this, there has to be emphasis and insistence upon initiation of enteral nutrition in the initial 24 to 48 hours. Talking about the types of EN feeds, as we know, there are standard polymeric feeds which contains macronutrients, and they are supposed to be a balanced diet with the equal or the optimum concentrations of carbohydrates, fats and sugars. And then a requirement of semi-elemental or peptide based feeds, where the patient does not tolerate the polymeric feeds, where semi-elemental feeds are easy to digest or absorb. They are considered when the patient has impaired digestion or malabsorption, or the period of crisis, where we again shift to polymeric feeds as soon as the period of crisis is over. Now, the special situations where we talk about the pulmonary or respiratory diseases, I think we will talk it in the next slides or the next video. That's all for now. Let's meet in my next video for the part 2 of nutrition in ICU. That's all for now. Thank you.